Welcome back to the Deep Dive. Today we're embarking on a mission really designed specifically for you, our listener, especially as you step into that, exciting but often challenging role of a new surgical pathology, attending your associate professor.
Yeah, it's a big step.
It really is. You're navigating the high-stakes world of independent sign-out, and we know that brings a unique set of complexities, particularly when those let's say, truly ambiguous cases land on your bench.
Absolutely. Those are the ones that keep you up at night, right?
Exactly. So our goal today is clear. We're going to take your source material on epithelioid and epithelial-like soft tissue tumors and, well, distill it into immediately actionable, really in-depth knowledge.
Kind of like a focus board review.
Think of it like that, yeah. But maybe with some expanded practical insights. Really trying to enhance your diagnostic confidence and sharpen those recognition skills for these often tricky entities. We want you to feel empowered at that sign-out bench.
And that confidence is just so vital. Distinguishing these tumors isn't just, an academic exercise. It carries profound clinical implications for patient management. These epithelioid and epithelial-like soft tissue tumors, they're notorious for their mimicry.
Right.
And a misdiagnosis or a misdiagnosis can lead to really significant treatment errors. So yeah, we're going to dive deep into those challenging differential diagnoses, emphasizing why each distinction is so critical for the patient on the other side of that slide.
Exactly. So how are we going to navigate this landscape? Well, we'll start with a systematic diagnostic approach.
Yeah.
Sort of your pathologist's compass, if you will.
Okay.
Then we'll delve into specific benign entities, followed by the more aggressive malignant ones. And finally, we'll explore those fascinating epithelioid variants of other sarcomas, the true shapeshifters that can catch even seasoned pathologists off guard.
Ah, the tricky ones.
Yeah, exactly. Our aim is to arm you with the essential morphologic, immunohistochemical, and molecular nuggets that will truly empower your confident sign-out. So let's unpack this.
Okay, let's kick things off with the foundational challenge for any independent pathologist. Epithelioid mesenchymal tumors. These are rare, yes, but they are master mimickers.
They really are.
They can look exactly like far more common non-mesenchymal tumors, and that's often the first critical hurdle you'll face, right?
Absolutely.
You're looking at tumors composed of cells that are rounded or polygonal, truly resembling epithelial cells. And they can adopt incredibly variable growth patterns, nested, sheet-like, strand-like, cord-like, even glandular-like architecture.
Yeah, the patterns can be all over the place.
And while some dermal lesions exist, our focus today is specifically on those found in deep soft tissue and the subcuvulate.
Right. And what's fascinating here is that while they are relatively rare, maybe 5% to 10% of soft tissue sarcomas overall, their epithelioid features make them a huge diagnostic pitfall.
This inherent mimicry is precisely why a thorough, systematic exclusion of non-mesenchymal mimics is absolutely paramount before you even start thinking about an epithelioid mesenchymal tumor. For a new attendant, this isn't just like good practice.
Right.
It's a non-negotiable first step. You have to do it.
That makes perfect sense. So let's talk about that crucial exclusion. Before we even entertain the idea of an epithelioid mesenchymal tumor, what are we absolutely sure we need to rule out first?
Okay, so before you commit, you must diligently exclude a whole list of non-mesenchymal entities.
Yeah.
This list includes things like metastatic carcinomas, which, could originate from anywhere: lung, breast, GI tract, or common sites.
Okay.
You also need to definitively rule out metastatic melanoma, malignant mesothelioma, and even hematologic malignancies like diffuse large B-cell lymphoma, plasmacytoma, or maybe anaplastic large cell lymphoma.
Wow, that's a broad list.
It is, and it's critical to remember that these non-mesenchymal entities can occasionally present primarily in soft tissue, which makes getting that clinical history absolutely crucial. You have to actively seek that information out.
So you can't just rely on the slide in front of you?
Absolutely not. And this leads to a vital practical tip for your independent sign-out. Reviewing previous pathology material for comparison isn't just helpful, it's a non-negotiable step.
Right.
If the patient has any history of a prior malignancy, you need to get those old slides. If that melanoma from 5 years ago now has a subcutaneous nodule, well, you're thinking metastasis first, not some exotic primary soft tissue sarcoma.
Makes sense.
This single step can save you immense time and, more importantly, prevent a potentially serious misdiagnosis.
That's a powerful reminder. The clinical history, then, becomes a really vital lens through which we view these cases. It's not just about the slide, it's about the patient. So how does that clinical context, things like patient age and sex, tumor location, size, relevant medical history, how does that help us narrow things down right at the beginning of our diagnostic journey?
Oh, the clinical lens is incredibly powerful. Patient age and sex, the exact tumor location, its size, and any relevant medical history like, say, a prior sarcoma, any radiation therapy, or even a family history of something like tuberous sclerosis or type 1 neurofibromatosis, all these provide critical clues.
Okay.
Certain demographics or histories immediately narrow your differential. For instance, some tumors are almost exclusively found in infants or children. Think extrarenal malignant rhabdoid tumors or congenital granular cell tumors.
Right.
While others, like maybe a pleomorphic liposarcoma with epithelioid features or myxofibrosarcoma, those are predominantly seen in middle-aged or elderly adults. Just knowing the patient's age can already cut your differential list significantly. And location is equally key. Consider tumors most likely found in the distal extremities, things like glomus tumors, sclerosing paraneuriomas, or maybe epithelioid sarcomas.
Okay.
Conversely, some tumors have very limited spots they like to show up in. Chordoma, usually sacrum or occiput. Adult rhabdomyoma, almost always head and neck.
Got it.
So by integrating this contextual information, asking those targeted clinical questions, you can significantly reduce the number of entities you need to seriously consider. It saves valuable diagnostic time and resources. It's really about working smarter, not just harder, especially when you're starting out.
So once we've considered the clinical context and, excluded the obvious mimics, we move to the microscopic examination. This is really the bread and butter of surgical pathology, isn't it? What's the blueprint here? What H&E features should we be zoning in on to make that first informed assessment?
Right, the H&E. On H&E, you're primarily evaluating three things: the cell arrangement or growth pattern, the cytomorphologic appearance of the cells themselves, and the quality of the extracellular matrix or stroma. These are your essential first-pass filters.
Take three things.
Yeah. At low power, some sarcomas are almost instantly recognizable by their growth pattern. Think of alveolar soft part sarcoma, ASPS, right? With its characteristic pseudoalveolar pattern.
Classic.
Or maybe the presence of actual glandular structures, which immediately points you towards possibilities like synovial sarcoma. Others, though, like epithelioid sarcoma or epithelioid angiosarcoma, they'll have more complex and variable patterns. So for those, you really need to scrutinize the individual cells more closely.
And when you say scrutinize the individual cells, what specific details are you looking for in their cytomorphology? What should jump out at us?
It truly is crucial. Pay close attention to the nuclei and the cytoplasm. Many epithelioid soft tissue neoplasms, think epithelioid sarcoma, ASPS, epithelioid angiosarcoma. They often exhibit these vesicular nuclei with a single prominent central nucleolus. Ah, okay. That prominent nucleolus.
Exactly. That's a very helpful signpost for a subset of these tumors. In contrast, tumors like PEComas and GISTs often show nuclei with finer chromatin and maybe indistinct nucleoli. This subtle difference can significantly guide your thinking, even early on.
Interesting. And the cytoplasm.
The cytoplasm also offers vital clues. It can be copious or minimal, eosinophilic or clear, but look for specific features. Is it, say, vacuolated, like you might see in chordoma, EHE, or epithelioid angiosarcoma?
Okay.
Or are there rhabdoid inclusions, those eosinophilic cytoplasmic blobs? Those are characteristic of malignant rhabdoid tumor, epitheliosarcoma, or maybe myoepithelioma, myoepithelial carcinoma.
Gotcha. Rhabdoid inclusions.
Or perhaps you see melanin pigment pointing towards clear cell sarcoma or PEComa. These specific cytoplasmic features can be highly diagnostic. They act like immediate red flags or green lights for certain entities on your differential list.
It really sounds like every little detail on that H&E slide tells a part of the story. What about the stroma, the extracellular matrix? How does that factor into our initial H&E assessment? Ah, the stroma. Yes, the quality of the extracellular matrix is another crucial diagnostic clue. Sometimes it's poorly developed or practically absent, like an extrarenal malignant rhabdoid tumor or epithelioid MPNST.
Okay.
Other times, it's a prominent collagenous stroma, which is characteristic of something like undifferentiated pleomorphic sarcoma or epithelioid sarcoma. You might also see a very myxoid stroma, like an extraskeletal myxoid chondrosarcoma, myoepithelioma, or chordoma.
Right, that slimy look.
Exactly. Or perhaps a hyalinized to chondromyxoid stroma, sort of glassy or cartilage-like, which you often see in chondroid lipoma, myoepithelioma, or EHE. So these basic H&E features, the growth pattern, those nuclear and cytoplasmic details we talked about, and the stromal quality, these are your first-pass filters. They're absolutely essential for narrowing down your differential diagnosis and, crucially, guiding your subsequent ancillary studies laboratories, which, cost more time and money. Never underestimate the power of just careful H&E assessment to establish your working hypothesis.
Okay, here's where it gets really interesting for us pathologists, right? The place we often turn to for confirmation. Immunohistochemistry. It's truly the molecular fingerprint that confirms our suspicions. How indispensable is IHC for these epithelioid mesenchymal tumors, and what are the key markers or combinations we should be reaching for when you're at the sign-out bench?
Oh, IHC is almost always required for epithelioid mesenchymal tumors. It's not just for typing and subtyping the tumor itself, but equally important, it's for definitively excluding those non-mesenchymal mimics we discussed earlier, the carcinomas, melanomas, lymphomas, mesotheliomas.
Right, the rule-outs.
Exactly. When you're facing a challenging epithelioid lesion, you really need to think in terms of panels, not just single markers.
Good point.
Let's break down some key marker combinations. Epithelial markers like keratins, KRT, and EMA are absolutely crucial. They're strongly positive in carcinomas and mesotheliomas, obviously. But, and this is a critical nugget for you as a new attending perpany, you have to remember that many epithelioid soft tissue sarcomas also express these markers.
Oh, that's a big pitfall.
Huge pitfall. Think chordomas, myoepitheliomas, synovial sarcomas, epithelioid sarcomas, DSRCT, malignant rhabdoid tumors. They can all be keratin or EMA positive, so you can't just assume epithelial marker positivity automatically means carcinoma.
Okay, noted. What else?
Next, melanocytic markers like S100, HMB45, and melon A. These are vital for distinguishing entities like melanoma, of course, but also clear cell sarcoma, PEComa, granular cell tumor, and epithelioid MPNST. Then you have your muscle markers SMA, desmin, myogenin. These point towards things like glomus tumor, PEComa, rhabdomyosarcoma, and leiomyosarcoma.
Right.
Vascular markers CD34, CD31, ERG. Key for epithelioid hemangioendothelioma, epithelioid angiosarcoma, PEComa again, and epithelioid hemangioma.
Okay.
Then there's INI1 or SMRCB1. This one is a real game changer. Loss of INI1 expression when you see it's absent in the tumor cells but present in the background normal cells.
The internal control.
Exactly. That loss is the definitive signature for diagnosing epithelioid sarcoma and malignant rhabdoid tumor. Its presence or absence is an incredibly powerful differentiator in challenging cases. It's also important to remember that specific patterns of reactivity, diffuse versus focal, cytoplasmic versus nuclear, are just as important as a simple positive or negative result. IHC isn't just about presence, it's about the whole context, how the picture fits together.
That brings us to the cutting edge of modern pathology, cytogenetics and molecular testing. How did these studies, with their ability to unmask specific translocations or mutations, provide that ultimate diagnostic certainty, especially in those really ambiguous cases where maybe the IHC still leaves a sliver of doubt?
Yeah, molecular testing provides absolutely invaluable diagnostic certainty. It truly acts as the ultimate confirmation in many, many cases. A lot of sarcomas with epithelioid features harbor specific translocations that we can detect using techniques like conventional karyotyping, FIS, or RT-PCR. For instance, synovial sarcoma has that highly specific TX18 translocation, leading to the SS18, SSX1, or SSX2 fusions. This fusion acts like a unique genetic fingerprint, giving you incredibly high certainty in your diagnosis.
Right.
Similarly, alveolar soft part sarcoma, ASPS, is defined by the TX17 translocation, resulting in the ASPS-CR1-TFE3 fusion. Knowing these specific genetic alterations gives you a level of confidence that morphology and even IHC alone just cannot always provide.
So it really clinches it sometimes.
It really does. PEComas, for example, often show TSC1 or TSC2 mutations, which lead to mTOR pathway deregulation or sometimes specific TFE3 rearrangements. And as we just discussed, epithelioid sarcoma and malignant rhabdoid tumors are characterized by some RCB1, INI1 mutations or deletions, leading to that loss of protein expression we see on IHC. Sclerosing epithelioid fibrosarcomas have specific UWSR1 CREB3 ML1 CREB3 L2 or FUS CREB3 L1 L2 fusions. These molecular findings are increasingly definitive, especially in those ambiguous cases where the morphology and IHC might overlap or be confusing. Knowing these specific genetic alterations provides invaluable diagnostic certainty, not just for you at the sign-out bench, but also because these molecular signatures are increasingly guiding targeted therapies. This is truly the ultimate aha moment for difficult cases, confirming the diagnosis and often dictating patient management, particularly when precise classification is needed for targeted treatment options.
Now that we have a solid systematic approach, let's transition into some specific entities, starting with those that are typically benign. But, benign doesn't always mean easy, does it? Especially in pathology.
Oh, absolutely not, especially not in this category.
These can still present significant diagnostic challenges, particularly when you're making that independent call for the first time. Let's start with epithelioid hemangioma. What are the key features that distinguish this from its more aggressive mimics, especially when you're trying to sign it out?
You're absolutely right. Benign doesn't mean straightforward here. Epithelioid hemangioma mostly affects adults, maybe 20, 40 years old, predominantly women. It often pops up in the head and neck, especially around the ear.
Yeah.
Superficial lesions are usually small, solitary, or sometimes multiple bluish nodules, occasionally ulcerated. Rarely you can see them in deep, soft tissue, and then they tend to be larger and infiltrative, often wrapped around large veins.
And pathologically, what's the look?
Pathologically, it's typically a circumscribed, often lobulated lesion. Histologically, it's a mixture of small capillary-sized vessels, bland epithelioid cells, and usually a pretty prominent inflammatory infiltrate, lots of eosinophils and lymphocytes typically.
Okay.
A classic diagnostic nugget to look for is the presence of these epithelioid endothelial cells that are sort of hobnail-like, protruding into the lumina, almost like tombstones.
Ah, the tombstone cells.
Exactly. The cells have copious eosinophilic to amphiphilic cytoplasm. Sometimes it's vacuolated. Nuclei are small, vesicular, with small central nucleoli. Crucially, you won't see significant atypia or necrosis, and mitosis are scarce. You do need to be aware of cellular variants that can sometimes obscure the vascular architecture, and there's also an intravascular type that can occur within large veins.
And what about the IHC for epithelioid hemangioma? Are there any specific markers that really help it stand out, particularly against its more worrisome mimics?
Yeah, the IHC for epithelioid hemangioma is pretty straightforward for vascular markers. CD31, CD34, ERG, and FLI1 are all positive. CD31 tends to be the most sensitive. Now, a potential pitfall for you as a new attending is that focal keratin positivity can actually be seen in about 10% of cases.
Oh, really?
Yeah, so don't let that immediately push you towards carcinoma. What's particularly useful for definitive diagnosis and a key distinguishing feature from other epithelioid vascular tumors is the overexpression of FOSB in about half of the cases. This is often due to FOSB gene rearrangements and is a really helpful differentiator.
Okay, FOSB. Good tip. What about the differential?
Given its potential for mimicry, the critical differential diagnoses include things like bacillary angiomatosis, but that has neutrophils and you can often see the bacteria. More importantly, you'll need to distinguish it from epithelioid hemangioendothelioma, EHE.
Right.
EHE is typically larger, more atypical, presence with cords and nests in that characteristic myxohyaline stroma, and crucially, it's consistently CAMT1 positive by IHC. That's a major differentiator.
Yeah.
Epithelioid angiosarcoma, on the other hand, shows marked nuclear atypia, sheet-like growth, necrosis, and high mitosis, clearly malignant features. Epithelioid sarcoma is diffusely positive for keratins and EMA, usually CD34 positive, and crucially shows loss of INI1, which epithelioid hemangioma retains. Myoepithelioma will be positive for epithelial markers, S100 and SOX10, but negative for CD31, CD34. Prognostically, epithelioid hemangioma can recur locally in about 30% of cases, but it doesn't metastasize, so complete surgical excision is curative.
Let's move to glomus tumor. This is another small lesion, but it can cause big pain, right? What are the nuances here, and what forms should we be aware of to ensure we don't miss its characteristic features?
Yeah, glomus tumors account for a small percentage of soft tissue tumors, maybe 0.5, 1.5%. They primarily affect middle-aged adults, often in the distal extremities. There's a female predominance for subungual lesions under the fingernail.
Ah, the painful ones.
Exactly. They are exquisitely painful and remarkably sensitive to cold or touch. That's a key clinical nugget to remember. They can be solitary, which is most common, or in familial forms, they can be multifocal and appear in children as glomuvinous malformations, usually in superficial soft tissues of the arms and legs.
And what do they look like under the microscope?
Pathologically, they're typically small, blue-red nodules, usually less than a centimeter. Histologically, they're a characteristic mix of three things: small, rounded, uniform epithelioid cells with these punched-out nuclei and sharp borders, the glomus cells themselves, small capillary-sized vessels surrounded by these glomus cells, and often smooth muscle bundles mixed in. Okay. A hyaline or myxoid stroma is common. Benign forms, which are the vast majority, show essentially no atypia or mitosis. There are variants, though. The epithelioid or oncocytic glomus tumor has large polygonal cells with abundant eosinophilic cytoplasm. And the symplastic glomus tumor shows degenerative atypia, which can look scary but is benign. Malignant forms are exceptionally rare and are defined by having both marked atypia and significant mitotic activity.
What's the immunohistochemical profile for glomus tumor, and what's the golden rule for differentiating it from its mimics, especially for a new attending facing maybe a small biopsy?
The glomus cells show strong reactivity for smooth muscle actin, SMA, muscle-specific actin, and H-caldesmin. Desmin can be focally positive in maybe 20% of cases, and CD34 can also be focally positive, mainly in the vascular component. Critically, S100, CD31, and epithelial markers are consistently negative. This immunoprofile is key for diagnosis.
Right, the negative markers are just as important.
Absolutely. Molecularly, about 60% of glomus tumors have NOTCH gene rearrangements, with NOTCH2 rearrangements predominating in the rare malignant forms, and MIR143 NOTCH fusions are also seen.
Okay, and the differential?
The differential diagnosis includes things like nodular hydrodenoma, which is positive for keratins, EMA, and CEA, unlike glomus tumors. And intradermal melanocytic nevus would be S100 positive. Carcinoma is excluded by clinical history and being keratemia positive but SMA negative. When you're looking at vascular mimics, differentiating glomangioma from a cavernous hemangioma relies on seeing that rim of glomus cells in the glomangioma. For things like glomangiomyoma or glomangioparasitoma, the distinction from myofibroma or leiomyoma is often not clinically critical as they're sort of related benign entities on a spectrum.
And prognosis?
Prognostically, local recurrence is about 10%. Malignant glomus tumors are truly rare. The crucial diagnostic nugget for malignancy is marked atypia plus any mitotic activity or atypical mitosis. They can metastasize in a subset of these truly malignant cases. There's a helpful category of uncertain malignant potential for superficial lesions that might have numerous mitoses but lack atypia, or for tumors that are large or deep-seated. These usually behave benignly. Complete surgical excision is the standard treatment.
Moving on to myoepithelioma, mixed tumor, and myoepithelial carcinoma of soft tissue. Okay, this sounds like a true master of disguise, mimicking salivary gland tumors outside their usual home. What are we looking for here, and what makes these so morphologically heterogeneous?
Yeah, myoepithelial neoplasms of soft tissue really do mirror their salivary gland counterparts, and they span the whole spectrum from benign myoepithelioma to malignant myoepithelial carcinoma. They typically occur in the limbs and limb girdles of middle-aged adults, maybe median age 40-50, slight male predominance. Often found in the subcutis or deep soft tissue, usually presenting as a painless mass.
Okay, and the look?
Pathologically, they're often well circumscribed or nodular, but some can be infiltrative. They frequently have gelatinous or myxoid areas, sometimes even calcification or ossification. Necrosis is rare in the benign forms. Histologically, they are strikingly heterogeneous. That's the key word.
Heterogeneous.
Very. You see cords, strands, nests of epithelioid cells, sometimes spindled cells too. And these cells are set in a highly variable extracellular matrix, can be hyalinized, almost scar-like, or very chondromyxoid, like cartilage. The epithelioid cells are typically large, with clear to eosinophilic cytoplasm. They can have this characteristic plasmacytoid appearance, sometimes with hyaline cytoplasmic inclusions. That's a key diagnostic feature to note.
Plasmacytoid cells.
Metaplastic cartilage or bone shows up in maybe 10–15% of cases. Actual ductal differentiation can occur, and that's when you might call it a mixed tumor of soft tissue. The malignant forms, myoepithelial carcinoma, are generally larger. They show definite nuclear atypia, increased mitotic activity, and necrosis is present in maybe 40% of cases.
The IHC profile for these tumors seems quite broad. What's the immunophenotype that's most helpful for distinguishing them, especially given that mimicry and heterogeneity?
Right. The IHC is key because of the heterogeneity. Myoepitheliomas are characterized by expressing both epithelial markers keratins in most cases, EMA in about 2/3, and S100 protein in the vast majority.
Both epithelial and S100. That's unusual.
It is, and it's very characteristic. Other markers like calponin, GFAP, SMA, and desmin can also be positive to varying degrees. SOX10 is positive in most myoepitheliomas, making it another very useful marker. And here's a crucial diagnostic nugget for the malignant end of the spectrum: myoepithelial carcinoma, particularly in pediatric cases, up to 40% can show loss of INI1 expression.
INI1 loss again, but in a different context.
Exactly. Genetically, about half have EWSR1 gene rearrangements with diverse fusion partners. Some have FUS or pledge1 rearrangements instead, which tend to be mutually exclusive with EWSR1.
So the differential must be huge then.
It's extensive. You need to distinguish benign myoepithelioma from extraskeletal myxoid chondrosarcoma, EMC. EMC also has a lobulated pattern with cords and strands in a myxoid matrix, but it's less consistently S100 positive, usually epithelial marker negative, and has specific NR4A3 fusions. Metastatic chordoma is more uniform, BRCA positive, and lacks the heterogeneity. Ossifying fiber myxoid tumor, OFMT, has that characteristic peripheral bone rim and is generally keratinema negative. Epithelioid schwannoma is strikingly S100 positive, but epithelial negative. Chondroid lipoma has lipoblast-like cells.
Okay, and for the malignant ones?
For malignant myoepithelial carcinomas, the differential expands significantly. You're thinking epithelioid MPNST, high-grade EMC, sclerosing epithelioid fibrosarcoma, SEF, proximal type epithelioid sarcoma, metastatic carcinoma, metastatic melanoma. It was a long list.
Wow. What about prognosis?
Prognostically, these tumors definitely have the potential for both local recurrence and distant metastasis. Local recurrence rates are substantial, 35–40%, and metastatic rates are also high, maybe 30–40%, often going to lungs, lymph nodes, bone, and soft tissue. Interestingly, just having infiltrative margins alone doesn't reliably correlate with malignancy.
So what does define malignancy then?
The key criteria for diagnosing myoepithelial carcinoma are moderate to severe nuclear atypia, things like pleomorphism, vesicular or coarse chromatin, prominent nucleoli. It's important to note, and maybe a bit surprising, that mitotic activity and necrosis don't reliably correlate with outcome in these specific tumors. Deep or visceral sites typically carry a worse prognosis, and pediatric cases are more likely to be malignant. Complete excision with negative margins is key. The role of chemotherapy is still being figured out, though some agents like carboplatin paclitaxel have shown some promise for metastatic cases.
Let's talk about adult-type rhabdomyoma. This one can present a spider cell conundrum you mentioned. What defines this benign entity, and how do we avoid mistaking it for something more ominous like a rhabdomyosarcoma, especially in the head and neck?
Right. Adult-type rhabdomyoma is an extracardiac rhabdomyoma. It primarily occurs in the head and neck region, think oral cavity, base of tongue, larynx, pharynx, neck. Usually in middle-aged to elderly adults, age around 60, with a definite male predominance, maybe 3.1.
Okay.
They typically present as small, slow-growing, painless masses. Sometimes they cause hoarseness or swallowing difficulties just due to their location. About 20–30% of cases are multiple, but usually in the same anatomical area. Importantly, for this adult form, there's no association with tuberous sclerosis, unlike the cardiac type.
And pathologically, what are the spider cells?
Pathologically, they are usually solitary, well-demarcated submucosal nodules. Histologically, they consist of these tightly packed, rounded to polygonal cells with really abundant granular eosinophilic cytoplasm. The nuclei are small and vesicular with small nucleoli. A classic feature, which is the diagnostic nugget here, is prominent cytoplasmic vacuolization. This clearing of the cytoplasm pushes the nucleus to the side and leaves these strands radiating outwards, giving that characteristic spider cell appearance.
Ah, I see, like legs of a spider.
Exactly. Intracytoplasmic crystalloid structures, sort of like what you might see in ASPS, are occasionally seen too. Crucially, adult rhabdomyomas show essentially no mitosis or necrosis. That's a major point of distinction from malignancy.
How does IHC help confirm this diagnosis and differentiate it from its mimics, particularly in that potentially tricky head and neck location?
Yeah, IHC for adult-type rhabdomyoma shows strong reactivity for skeletal muscle differentiation markers. So desmin, myoglobin, muscle-specific actin like HHF35, and skeletal fast myosin are all typically positive.
Okay, clear muscle differentiation.
Right. S100 protein and SMA are less frequently positive. Importantly, myogenin is typically negative unless the tissue has been somehow traumatized or manipulated before biopsy.
That myogenin negativity is key then.
Very key. The main differential is well-differentiated embryonal rhabdomyosarcoma. But that occurs in children or young adults, shows definite nuclear pleomorphism, has immature and mature rhabdomyoblasts, it's infiltrative, has mitosis and necrosis, and importantly, it's strongly positive for myogenin and MYOD1. Alveolar soft part sarcoma also has large eosinophilic cells and can be in the head and neck, but it shows that classic alveolar pattern, has larger vesicular nuclei with prominent nucleoli, and is TFE3 nuclear positive. Other mimics include granular cell tumor, which is diffusely S100 positive but lacks skeletal muscle differentiation. Hibernoma, usually found in interscapular regions, looks like brown fat. And crystal-storing histiocytosis is CD68, CD163 positive and related to lymphoplasmacytic neoplasms, lacking muscle markers. Prognostically, adult-type rhabdomyoma is benign. Simple excision is curative, although local recurrence can happen in 15–40% of cases if it's incompletely excised.
Let's discuss granular cell tumor. It's known as an S100 powerhouse, but it still has its diagnostic challenges, particularly when it presents in deep soft tissue or when you're considering its rare malignant forms. What are the telltale signs for a new attending?
Granular cell tumors are most common in the tongue, skin, and subcutis, yeah. But they absolutely can appear in deep, soft tissue, particularly in proximal extremities in the trunk. They affect middle-aged adults with a female predilection. While most are solitary, about 10% of patients, especially those of African American descent, can have multiple lesions, and it's really crucial to remember that approximately 2% are clinically malignant.
Only 2%, but important not to miss.
Exactly. Deep soft tissue lesions tend to be larger, maybe 5 to 7 centimeters, and often have ill-defined infiltrative borders, which can definitely raise suspicion right away.
Okay. And the histology, what makes them granular?
Pathologically, they form sheets, cords, ribbons, or nests of rounded to polygonal cells, typically separated by dense collagenous stroma. The defining feature and the key diagnostic nugget is that abundant, eosinophilic, finely granular cytoplasm with ill-defined borders. Those granules are actually dilated lysosomes or phygolysosomes.
Ah, okay. Lysosomes.
Yeah. Nuclei are typically small and dark, or sometimes larger and vesicular. Benign lesions lack mitosis and necrosis. They commonly surround and infiltrate nerves, which can be a very helpful clue when you see it. Malignant granular cell tumors, however, show marked nuclear atypia, vesicular nuclei with large nucleoli, often some cell spindling, clear evidence of mitotic activity, and alor necrosis.
So if we see those granular cells, what's the go-to IHC, and what are the crucial distinctions in the differential, especially against malignant melanoma, which can also be S100 positive?
For granular cell tumor, the IHC is quite distinctive. Strong and diffuse S100 protein and SOX10 positivity. That reflects their Schwannian differentiation.
Strong and diffuse S100 and SOX10.
Yes. Calretinin, inhibin, CD68, CD57, and KGP 9.5 are variably positive too. Interestingly, nuclear TFE3 is seen in about 90% of cases, though it's not always correlated with an actual rearrangement. Importantly, they are negative for neurofilament and GFAP. In the rare malignant forms, strong p53 staining and a high MIB1 index, typically over 10%, are often seen and are crucial for recognizing aggressive potential.
Okay. And differentiating from melanoma?
Right. The differential includes other lesions with granular cells like adult rhabdomyoma, hibernoma, various sarcomas or carcinomas with granular changes. But the strong and diffuse S100 usually distinguishes granular cell tumor from most of these. The golden rule to distinguish it from melanoma, while both are S100 SOX10 positive, granular cell tumor is consistently negative for HMB45 and melon A.
Ah, negative HMB45 melon A, that's key.
Very key. Prognostically, most are benign. Simple excision is curative with less than 5% local recurrence. Malignant cases are rare, maybe 2%. Malignancy is usually defined by having at least 3 of these features: marked pleomorphism, high nuclear to cytoplasmic ratio, vesicular nuclei with large nucleoli, cell spindling, more than 2 mitosis per 10 high-power fields, or tumor necrosis. There's an atypical granular cell tumor category with only 1 or 2 of these features, and those generally do not metastasize. Malignant forms, however, have high recurrence and metastasis rates, with a significant percentage of patients dying within 3 years. Wide excision and sometimes adjuvant radiation are needed for malignant cases.
Extracranial meningioma, while rare in soft tissue, is another entity that can pop up unexpectedly, maybe in the scalp or near the spine. What are the key features for recognizing this ectopic presentation, especially when it might be confused with other benign lesions?
Yeah, extracranial meningioma typically arises in the skin or soft tissues of the scalp, or near the vertebral column. Often seen in children or young adults, sometimes it's congenital, and some cases seem linked to neural tube closure abnormalities. They usually present as well-demarcated masses.
Okay. And pathologically, do they look like regular meningiomas?
They do. They closely resemble their intracranial counterparts, showing nests and whorls of meningothelial cells, often with psammoma bodies. However, they often have a more infiltrative growth pattern in soft tissue. There's also a variant, the ectopic meningothelial hamartoma, which can be microcystic and look somewhat angiosarcoma-like, particularly when it occurs in the scalp.
Okay. What else? Stains.
IHD shows consistent positivity for EMA, SSTR2, and progesterone receptor. Rarely, they can express keratins, which could be a diagnostic pitfall if you're not thinking meningioma. The critical practical tip for any attending signing these out is to always exclude the possibility of extracranial extension from an intracranial tumor before diagnosing a primary extracranial meningioma. You really need that clinical and imaging correlation.
Next, ossifying fibromyxoid tumor, or OFMT. This one has that unique bony rim that sounds like a key clue. What else should we know about its appearance and how to nail the diagnosis?
OFMT occurs in middle-aged adults with a male predominance, mainly in the extremities, trunk, and head neck. It's usually found in the deep subcutis, less commonly in deep soft tissue. Pathologically, conventional OFMT has rounded to ovoid or short spindle cells arranged in cords and strands, set within a fibromyxoid to hyalinized collagenous stroma.
Okay, and the epithelioid variant.
The epithelioid variant, which is our focus here, has prominent, bland-looking epithelioid cells with eosinophilic or clear cytoplasm, really mimicking an epithelial neoplasm sometimes. The nuclei are round, small, and vesicular with small nucleoli, and mitoses are very rare, making it look deceptively low-grade. The highly helpful diagnostic feature, a true golden nugget, is that incomplete rim of mature lamellar bone at the periphery. You see this in about 80% of cases, though sometimes it's just internal foci or rarely completely absent.
That bony rim sounds pretty specific. What about IHC?
IHC shows S100 protein positivity in about 70% and desmin in up to 50%. NSC and GFP are occasionally focal. Crucially, OFMT is generally negative for epithelial markers like keratins and EMA, which helps immensely when you're thinking about carcinoma mimics. Molecularly, most cases, about 85% have PHF1 gene fusions, often PHF-EP400 or related BCOR gene fusions. FEF for PHF1 locus rearrangement can be a helpful confirmatory test.
And the differential for OFMT?
The differential includes myoepithelioma, which can have epithelioid and spindle cells but lacks the peripheral bone. Usually has a more myxoid chondromyxoid matrix, and is positive for keratin-CMUS 100 GFAP. Nerve sheath tumors are S100 positive but lack the uniform architecture, cords of cells, and peripheral bone. Extraskeletal myxoid chondrosarcoma, EMC, is typically deep-seated, multinodular, has abundant myxoid matrix, no bone, and S100 positivity is less consistent. Prognostically, local recurrence happens in maybe 10–20% of cases. Malignant cases are usually defined by being large, deep-seated, highly cellular, showing clear nuclear atypia, increased mitosis, and maybe having bone foci within the tumor rather than just at the periphery.
Finally, for our benign section, ependymoma of soft tissue. This sounds like a sacrococcygeal surprise, often with classic features that might trick you into thinking of something else, maybe a sweat gland tumor.
Indeed. Ependymomas of soft tissue are rare. They're typically found in the subcutaneous tissue dorsal to the sacrum or coccyx, or less frequently, in the presacral deep soft tissue. Some are associated with developmental abnormalities like spina bifida. They present as well-demarcated masses, and clinically, they can mimic teratomas or sweat gland tumors.
What's the histology? Does it look like CNS ependymoma?
It does, very much so. Histologically, they are often lobulated and myxoid. They're composed of epithelioid cells, sometimes looking almost carcinoid-like, often forming capillary structures and classic perivascular pseudosets. That's a key morphologic nugget. They strongly resemble myxopapillary ependymomas that you'd see in the cauda equina.
And IHC. Any pitfalls there?
IHC reveals GFA positivity, which you'd expect, but also, critically, they are often positive for keratins. This can be a significant diagnostic pitfall, potentially making you think of a carcinoma. However, EMA is consistently negative, which is a key differentiator against true epithelial lesions.
Okay, GFA positive, keratin positive sometimes, but EMA negative.
Exactly. Prognostically, complete surgical excision is the treatment of choice. However, unlike many benign entities, these actually have the capacity to metastasize, often late, to regional lymph nodes or lungs in maybe 20–30% of cases. So, long-term follow-up is definitely important for these patients.
Okay, now let's pivot to the truly high-stakes diagnoses, the malignant epithelioid tumors. For you, as a new attending, getting these right is absolutely paramount because it directly impacts patient prognosis and treatment options. Let's start with perivascular epithelioid cell tumor, or PEComa. This one's known for its melanocytic myoid paradox, which could be quite confusing.
A paradox, you say? What exactly is a PEComa, and what makes it such a complex entity to diagnose, especially when we're talking about epithelioid forms showing up in soft tissue?
Right, the concept of PEComa encompasses a whole family of neoplasms characterized by the specific perivascular epithelioid cell differentiation. What that means is the cells uniquely show features of both smooth muscle differentiation and melanocytic differentiation. It's weird, right?
Yeah, that's a strange mix. It is. This group includes well-known entities like angiomyolipoma, AML in the kidney, lymphangioliomyoma, LAM in the lung, and clear cell sugar tumor, CCST. There is a significant association with tuberous sclerosis complex, TSC, though many cases are sporadic. While they were first described in places like the kidney, lung, and liver, we're increasingly recognizing them in soft tissues, skin, bone, and other organs. When it's not specifically AML or LAM, we use the umbrella term PEComas, or just PEComa.
Okay. And clinically, where do they show up?
Clinically, these are rare and they mostly affect women. While AMLs are common in the kidney, PEComas can really be found almost anywhere. Retroperitoneum, uterus, vulva, GI tract, skin, soft tissue, you name it. Clinical features depend entirely on the location and size. For example, renal AMLs in patients with TSC are often bilateral, multiple, small, and asymptomatic, whereas sporadic ones can be larger and cause symptoms like pain or hematuria.
And pathologically, what are the characteristic features, especially for these epithelioid variants, and how do we spot that unusual co-expression of markers at the bench?
Grossly, AMLs are often yellow-gray and unencapsulated, sometimes infiltrating, maybe with hemorrhage or necrosis. Epithelioid AMLs, which morphologically are pretty much indistinguishable from PEComas, are composed predominantly or exclusively of large polygonal epithelioid cells. They have abundant, pale eosinophilic granular to clear cytoplasm. Fat and vessels, the other components of classic AML, can be focal or even absent. When vessels are present, they're often thick-walled.
Okay.
You might see nests of tumor cells surrounded by delicate capillaries, which can sometimes mimic renal cell carcinoma. Nuclear atypia and multinucleated giant cells are common, and hemorrhage or necrosis can definitely occur, especially in the larger or more aggressive ones.
Sarcomas in general.
Generally, PEComas have a really wide morphologic spectrum. They're characterized by these large polygonal epithelioid cells, granular eosinophilic to clear cytoplasm, often growing in nests and frequently associated with vessel walls. Multinucleated giant cells can be seen. Sometimes you see spindled cells with clear cytoplasm, more like a CCST. There's even a specific variant called sclerosing PEComa, often in the retroperitoneum, which has marked stromal hyalinization and a trabecular architecture. Occasionally, you can even find melanin pigment, which adds another layer to the diagnostic challenge.
Right, because of the melanocytic connection. So the IHC is key.
Absolutely key. Immunochemically, that characteristic co-expression is the golden rule. Strong positivity for smooth muscle markers like SMA in about 80%, and melanocytic markers like HMB45 in about 90%, or melan A in about 70%.
SMA and HMB45 melan A together.
Exactly. HMB45 typically shows granular cytoplasmic staining. Desmin is less common, maybe 30%, and S100 is even rarer, maybe 10%. Importantly, some clear cell PEComas might only be positive for the melanocytic markers. Critically, keratins, EMA, KT, and CD34 are usually negative. Estrogen and progesterone receptors are often positive in AMLs. About 20% show nuclear TFE3 staining, which can correlate with TFE3 rearrangements. That's a potential pitfall for differentiating from ASPS. Cathepsin K is sometimes mentioned, but is less specific.
That co-expression is truly unique, but the differential diagnosis for PEComa is notoriously complex, you mentioned. How does that marker profile help us navigate the incredibly wide array of potential mimics? There seem to be so many possibilities.
The differential for PEComa is indeed very complex because of its overlapping features. For an epithelioid AML in the kidney, you need to distinguish it from renal cell carcinoma, RCC, which is KR-TMA positive and generally melanocytic negative, with the rare exception of TFE rearranged RCCs. You also need to think about epithelioid melanoma, which is strongly S100 SOX10 positive, but generally SMA-Desmin negative. Rhabdomyosarcoma is Desmin myogenin positive. Epithelioid leiomyosarcoma is muscle marker positive, but melanocytic negative. Epithelioid sarcoma is positive for epithelial markers, often CD34, and shows INI1 loss, but is melanocytic negative. Malignant rhabdoid tumor also has INI1 loss. Epithelioid GIS is KIT CD34, DOG1 positive, has KIT-T PDG or VRA mutations, and lacks melanocytic markers.
What about ASPS? That TFE3 overlap sounds tricky.
Right, alveolar soft part sarcoma ASPS is a tricky one. It has that nested pattern and can have nuclear TFE3 positivity, just like some PEComas, but ASPS is consistently HMB45 negative. That's your key distinguishing marker. HMB45 positivity strongly favors PEComa.
HMB45 is the tiebreaker there.
Often, yes. For PEComa in general, soft tissue, you're also ruling out metastatic carcinomas from various sites, liver, adrenal, kidney, Metastatic melanoma, strong S100 SOX10, mesothelioma, KR-T-methylretinine WT1 positive. Myoepithelioma is epithelial marker, SMA S100 positive, but melanocytic negative. Epithelioid angiosarcoma is CD31ERG positive, but melanocytic negative. Clear cell sarcoma is S100 melanocytic positive, but has specific translocations. Even large cell lymphomas need to be considered. The key here is really running a broad panel, and specifically looking for that co-expression of melanocytic and smooth muscle markers. That's the PEComas signature.
And the prognosis, is it always malignant?
No, the behavior is highly variable. Conventional AMLs are usually benign. Epithelioid AMLs, however, contain an aggressive subset capable of recurrence and metastasis. For PEComas in general, aggressive predictors include marked nuclear atypia, definite pleomorphism, a high mitotic rate, like more than 1 per 50 high-power fields, necrosis, and for renal tumors, extrarenal extension. Size greater than 5 centimeters is also concerning. Mitotic activity often carries the highest predictive value. We typically classify a PEComa as, frankly, malignant if there's any mitotic activity combined with marked nuclear atypia or diffuse pleomorphism. Importantly, because many PEComas have alterations in the TSC genes leading to mTOR pathway deregulation, drugs like sirolimus, an mTOR inhibitor, have shown efficacy for AMLs, LAM, and some metastatic PEComas. This really highlights the importance of precise diagnosis for potential targeted therapy.
Alveolar soft part sarcoma, ASPS. This one is known for its distinct TFE3 translocation and its, well, notorious high metastatic potential, even when the primary tumor seems subtle. For a new attending, this is one you absolutely cannot afford to miss, right?
Absolutely. ASPS is uncommon, but it punches way above its weight in terms of aggressiveness. It primarily affects adolescents and young adults, maybe 15-35 years old, with a female predominance. It's often a deep-seated intramuscular mass. Location-wise, it's typically the lower extremities, like the thigh, in adults. In children, it's more common in the head and neck, like the periorbital region or the tongue.
Okay.
A critical clinical nugget is that it can be asymptomatic for years. Sometimes the first sign of disease is actually distant metastases showing up in the lungs, brain, or bone.
Wow, presence with Mets.
Yeah. Unfortunately, that's not uncommon. Pathologically, ASPS is often ill-defined, grossly, soft, grayish, and necrosis or hemorrhage are common. Histologically, it's characterized by that classic lobulated, monotonous nested alveolar or pseudo-alveolar growth pattern. This pattern results from loss of cell cohesion, leaving cells clinging to delicate vascular septa.
That alveolar pattern is key.
It really is. The epithelioid cells themselves have abundant, granular, eosinophilic, sometimes clear cytoplasm. Those PAS-positive, diastase-resistant crystals or granules are characteristic, but they're not required for the diagnosis. Nuclei are large and vesicular with prominent central nucleoli. There's delicate sinusoidal vascular stroma separating the nests, and finding tumor cell emboli within veins is common. Mitotic figures are typically rare, which can be misleadingly reassuring. There's also a solid variant, more common in children's tongues, with a compact proliferation and often a slightly better prognosis.
Given its distinctive molecular signature, how do IHC and molecular testing definitively nail down the diagnosis for ASPS? And what are the crucial differential considerations, particularly with things like PEComa, this can also be TFE3 positive, and renal cell carcinoma?
Right, the molecular is key here. Immunochemically, ASPS is generally negative for neuroendocrine and epithelial markers. It might show some muscle-specific actin positivity, but desmin is rare. The diagnostic marker, and your golden rule for ASPS, is using anti-TFE3 antibodies. You get characteristic strong nuclear staining.
Nuclear TFE3.
Exactly. Molecularly, nearly all cases have that unbalanced translocation involving chromosomes X and 17 specifically, TX17, P11, Q25. This fuses the TFE3 gene on XP11.2 with the ASP-SCR1 gene on 17q25. This translocation is highly specific for ASPS, though. As a heads up, it can also be found in a rare variant of renal cell carcinoma called XP11 translocation RCC, particularly in children. SC is widely used for detecting this fusion.
Okay, so the TFE3, IHC, and the fusion are definitive. What about mimics?
The differential diagnosis is important. Metastatic renal cell carcinoma, especially the eosinophilic clear cell type, can look similar, but RCC is usually positive for KRT, EMA, and PECx8, while ASPS is negative for these.
Yeah.
As mentioned, XP11 translocation RCCs are also TFE3 positive, so clinical context, kidney primary versus soft tissue, and a broader panel are key. Malignant granular cell tumor, Extrarenal malignant rhabdoid tumor and rhabdomyosarcoma generally lack that delicate vascular stroma of ASPS. Granular cell tumor is S100SOX10 positive. Rhabdomyosarcoma is Dismin myojonin positive. Malignant rhabdoid tumor is Keratima positive, and crucially, INI1 lost. Metastatic melanoma can look similar, but is S100SOX10 positive. Paraganglioma is positive for neuroendocrine markers. PEComa, as we discussed, can be TFE3 positive, but PEComa is usually SMA positive and, most importantly, HMB45 or melanA positive, which strongly distinguishes it from ASPS. ASPS is HMB45 negative. Epithelioid angiosarcoma lacks the uniform alveolar pattern and is positive for endothelial markers like CD31ERG.
And the prognosis for ASPS, you mentioned it's aggressive.
It has a high tendency to metastasize, especially to the brain, lungs, and bone, often late in the disease course, sometimes years later. Lymph node metastases are rare. The 5-year overall survival for localized disease is relatively high, maybe around 87%, but the median overall survival can stretch to 11 years, reflecting late progression. Only about 15–20% of patients are disease-free at 20 years. For metastatic disease, the prognosis is much poorer, with the 5-year OS around 20%. Local recurrence happens in about 20–30%. Favorable prognostic factors include localized disease, tumor size less than 5 centimeters, and younger age. Particularly those childhood head-neck cases seem to do a bit better.
Next, epithelioid hemangioendothelioma, or EHE. This is another vascular tumor, but is classified as a sarcoma with intermediate biologic potential. What makes it so tricky, especially with its unique molecular story involving those WWTR1, CAMTEL1, or YAP1 TFE3 fusions?
EHE is a fascinating vascular tumor, now classified as a sarcoma, that can arise in deep, soft tissues, but also characteristically in the lungs, liver, and bones. It can even be multicentric. It affects adults, median age around 50, no strong sex predilection. Can be superficial or deep, often in extremities, head, neck, trunk, or mediastinum. Median size is relatively small, typically 1 to 3 centimeters.
Okay, and pathologically, what's the hallmark?
Pathologically, EHE often presents as solitary nodules, frequently associated with or arising from a large vein, which can sometimes be thrombosed. The histological hallmark is infiltrative cords, strands, or nests of epithelioid cells set within a distinctive myxohyaline stroma, sort of a glassy bluish background. That stroma is a key morphologic nugget.
Myxohyalin stroma, got it.
The cells themselves have abundant, glassy, eosinophilic cytoplasm, well-defined borders, and generally bland vesicular nuclei with small central nucleoli. Cytoplasmic vacuoles, sometimes containing red blood cells, are often seen and can occasionally give a signet ring cell-like appearance. Mitoses are typically few, and nuclear atypia is limited in conventional AHE. However, there's an aggressive or malignant variant.
Oh, okay.
This variant shows more compact or solid growth, marked atypia, pleomorphism, hyperchromasia, maybe some spindle cells, necrosis, and a higher mitotic rate. It can really mimic an epithelioid angiosarcoma. It's important to recognize that conventional and aggressive areas can coexist within the same tumor, so you need to sample well.
How does the IHC and molecular profile help us sort out EHE from its wide array of mimics, especially those aggressive variants that look like angiosarcoma? What's the key test?
IHC for EE shows consistent positivity for vascular markers like CD31, CD34, ERG, and sometimes D240. ERG and CD31 are generally the most sensitive. CD34 often highlights those cytoplasmic vacuoles nicely. Focal keratin positivity can occur in maybe 20–30% of cases, and SMA can sometimes be positive, but EMA is consistently negative. That's helpful. Importantly, INI1 expression is retained.
Okay.
The definitive diagnostic nugget and a critical differentiator comes from the molecular surrogates. Nuclear CAMT1 staining by IHC is positive in about 90% of EE cases, reflecting the underlying WWTR1 CAMT1 gene fusion. This marker is highly sensitive and specific, and it's incredibly useful for distinguishing EE from epithelioid angiosarcoma, which is CAMT1 negative, and epithelioid hemangioma, also CAMT1 negative.
CAMT1 is the key then for that fusion.
It really is for the most common type. A smaller subset of cases, less than 5%, have a YAP1 TFE3 fusion instead. These can show nuclear TFE3 staining, particularly in soft tissues of young adults, and often have a distinctive morphology. Both of these fusions involve genes in the hippo signaling pathway.
So the differential is broad.
Very broad. You have to exclude non-mesenchymal mimics like carcinoma, melanoma, mesothelioma. They're generally negative for vascular markers. Epithelioid hemangioma is smaller, more superficial, has well-formed vessels, prominent inflammation, is CAMT1 negative, but often FOSB positive. Myoepithelioma is positive for epithelial markers, S100, GFAP, SOX10, but negative for vascular markers. Epithelioid sarcoma is strong for keratosema, often CD34 positive, but CD31 negative, and crucially, INI1 is lost, whereas EE retains INI1. Pseudomyogenic hemangioendothelioma has plump spindle cells, strong keratins, ERG positive, but CD34 negative, FOSD positive, CAMTIC1 negative, and lacks the myxohyaline stroma. An epithelioid angiosarcoma, the toughest mimic for aggressive EE, shows more atypia, mitosis, solid sheets necrosis, lacks the myxohyaline stroma, and is consistently CAMTIC1 negative.
Okay, CAMTA1's really helpful there. How does EE behave? Is it always intermediate?
Its behavior is highly variable, ranging from quite indolent to frankly aggressive. Features like marked atypia, spindling necrosis, more than 2 mitoses per 10 high power fields, and solid angiosarcoma-like foci are generally associated with a poorer outcome, though the statistical significance can vary across studies. The DAERUP criteria attempt to stratify risk. Low-risk tumors are small, 3 centimeters, with low mitosis, A3 per 50 HPF, having a low metastatic rate and essentially no tumor-related deaths. High-risk tumors are larger, 3 centimeters, or have higher mitosis, 3 per 50 HPF, with significantly worse survival and higher metastatic rates. Metastases typically go to regional lymph nodes, lungs, liver, and bone. Wide excision with clear margins is the primary treatment. Regional lymph node dissection might be considered. Chemotherapy is generally not very effective.
Epithelioid sarcoma. Okay, this is a big one. Known for its pseudogranulomatous mimicry, and critically that INI1 loss. This sounds like one of those tumors where a new attending could easily get tripped up, maybe thinking it's something benign like a granuloma or even a carcinoma. Tell us how to avoid that pitfall and make the definitive diagnosis.
You're absolutely right. Epithelioid sarcoma is a distinctive and indeed challenging sarcoma. The conventional type typically involves the distal extremities, forearm, wrist, hand of young adults, maybe median age 30, with a male predominance. It often presents as a firm, slow-growing nodule or plaque in the skin, subcutis, tendon, or fascia. And it's often mistaken clinically for an inflammatory process, like an infection or chronic ulcer, especially when it occurs on flexor surfaces.
Okay.
Then there's the proximal type variant. This arises more centrally, pelvis, perineum, axilla, mediastinum, even genital tract.
Okay.
It tends to affect slightly older adults, median age around 40, and usually presents as a large infiltrative mass in deep, soft tissue. This type generally carries a more aggressive prognosis.
And pathologically, what's that pseudogranulomatous look?
Pathologically, conventional epithelioid sarcoma can be small, ill-defined dermal or subcutaneous nodules, or sometimes larger, more obviously necrotic masses. It's characterized by a proliferation of predominantly epithelioid cells, sometimes with spindled areas too. The cells usually show mild to moderate atypia, vesicular nuclei, and small nucleoli. There's often abundant intercellular collagen. The classic pitfall, and a key morphologic nugget, is the tendency to form nodules with central necrosis. This creates a pseudogranulomatous appearance that can strikingly simulate a rheumatoid nodule or granuloma annulare.
Wow, looks like inflammation.
Exactly. Mitotic activity is usually low in the conventional type, but perineural and vascular infiltration are common, which is a clue to its aggressive potential. Dystrophic calcification, bone formation, or chronic inflammation can also be seen.
And the proximal type, how does that look different?
Proximal type epithelioid sarcoma is typically multinodular. It's composed of large epithelioid cells, often with more abundant eosinophilic or amphiphilic cytoplasm, marked nuclear atypia, vesicular nuclei, and prominent nucleoli. Rhabdoid features those cells with eccentric nuclei, and glassy inclusions are common and can even predominate, making it a challenging mimic of malignant rhabdoid tumor. Necrosis is common in the proximal type, but you don't typically see that granuloma-like pattern. There's also an angiomatoid variant, which has hemorrhagic spaces and can mimic an angiosarcoma.
So, given these varied presentations and common mimics, granuloma, carcinoma, MRT, angiosarcoma, what's the definitive IHC, a molecular signature that helps us make the call? Especially with that critical INI1 loss, that seems like the golden rule here.
It absolutely is the golden rule. Immunochemically, epithelioid sarcoma consistently shows diffuse EMA and keratins, both low and high molecular weight positivity. Vimentin is also positive, CD34 is positive in about half of cases, and it's actually more often positive in the proximal type.
Interesting, CD34 positive.
Yeah, that can be a pitfall if you're thinking only vascular tumors are CD34 positive. Occasional SMA or S100 positivity can occur, but Desmin and CD31 are usually negative. P63 and keratin 56 are infrequent. But the hallmark, your ultimate diagnostic nugget for epithelioid sarcoma, is the consistent loss of INI1 sensorimetry V1 expression by immunohistochemistry. You see it lost in about 90% of conventional types and maybe 95% of proximal types. You absolutely need to see retained staining in the internal control cells, lymphocytes, and endothelial cells to be confident in the loss.
That INI1 loss is incredibly powerful then.
Extremely powerful. Molecularly, this reflects inactivation of the SMARCB1 tumor suppressor gene at chromosome 22q11. This usually happens via a monoallelic deletion combined with epigenetic silencing or sometimes rarer biallelic deletion. A very, very small subset of epithelioid sarcomas that do retain INI might instead show inactivation of a related gene, SMARCB4.
Okay, so the differential diagnosis is huge, right? What are the key distinctions?
It's extensive and critical. For the conventional type mimicking granulomas, granuloma annulare or rheumatoid nodule lack atypia and are negative for epithelial markers. Against carcinoma, squamous cell carcinoma is usually P63, and KRT56 diffuse positive retains INI1 and is CD34 negative. Melanoma is S100, SOX10 diffuse positive, often HMB45 melanA positive, and crucially retains INI1, though rhabdoid melanomas can sometimes express keratin focally. Epithelioid hemangioendothelioma, EHE, is CD31 positive and retains INI1. Epithelioid angiosarcoma is CD31 positive, retains INI1, and is EMA negative. Pseudomyogenic hemangioendothelioma has plump spindly epithelioid cells, is ERG positive, often CD34 negative, retains INI1, and is FOSB positive. Epithelioid MPNST is S100 SOX10 strong diffuse KRT negative, but does show INI1 loss in about 2/3 of cases, making that differentiation sometimes challenging based on INI1 alone. The S100 is key there. Extrarenal malignant rhabdoid tumor affects infant children, is predominantly rhabdoid, and has SMARCB1 mutations. Myoepithelioid carcinoma can also be in the differential.
And for the proximal type, that sounds like it overlaps with MRT and melanoma.
Exactly. Proximal type epithelioid sarcoma specifically can be confused with metastatic melanoma and extrarenal malignant rhabdoid tumor. While all three can have rhabdoid features and both MRT and epithelioid sarcoma lose INI1, proximal type epithelioid sarcoma affects young to middle-aged adults, is typically multinodular, and is usually less dominated by rhabdoid cells compared to MRT. MRT typically affects infants and very young children, has a very rapid clinical course, and often involves biallelic SMRCB1 mutations. TP53 mutations are also more common in MRT. Melanoma again retains INI1 and expresses melanocytic markers.
What about the prognosis for epithelioid sarcoma? It sounds pretty serious.
It has a protracted course. It likes to propagate along fascial planes, tendons, and nerves. Local recurrence, metastasis, and even death can occur 20 or more years after the initial diagnosis, which mandates very long-term follow-up. Prognosis depends heavily on the initial stage and whether it can be completely resected. The 5-year disease-specific survival for localized disease is around 75%, but it drops significantly, maybe to 49%, if there's regional spread at diagnosis. Recurrence rates are high, anywhere from 30–85%, really depending on the adequacy of the excision. Metastases occur in 20–60% of patients, often after recurrences, primarily going to the lungs, regional lymph nodes, which is common, 20–40%, bone, and scalp. Treatment usually involves radical surgery, wide excision, or sometimes even amputation. Conservative surgery combined with radiation is showing some promise. Lymph node dissection is typically performed only if metastases are clinically apparent. Adverse prognostic factors include male sex, older age, 75, large size, 5 centimeters, deep or proximal location, necrosis, nuclear pleomorphism, high mitosis, vascular or nerve invasion, inadequate excision margins, multiple recurrences, and having regional lymph node mets at diagnosis. And yes, the proximal type is generally considered more aggressive.
Let's briefly touch on SMARCK4 deficient thoracic sarcoma. This sounds like a close relative of epithelioid sarcoma, specifically linked with BRG1 loss. What sets it apart, and why is it important for a pathologist to recognize this specific entity?
Right. SMARCB4 deficient thoracic sarcoma is a relatively recently described entity. It's characterized by mutations in the SMARCB4 gene, which codes for BRG1, an ATPase subunit of the SWI-SNF chromatin remodeling complex. This leads to corresponding loss of SMARCB4 BRG1 and often SMARCB2 BRM protein expression by IHC. These tumors typically arise in the chest wall, pleura, or mediastinum, and interestingly seem to occur predominantly in male smokers.
Okay. And morphologically?
Morphologically and immunochemically, they can look quite similar to proximal-type epithelioid sarcoma. They often have large epithelioid cells, can be multinodular, and express EMA, keratins, and often CD34. However, the crucial distinguishing feature, and your golden rule here, is that they retain INI1, SMARCA1 expression, unlike epithelioid sarcoma.
INI1 retained, but SMARCA4 lost.
Exactly. They also consistently show strong SOX2 expression by IHC. These tumors can sometimes resemble poorly differentiated carcinomas, but the CD34 positivity generally argues against carcinoma, and they typically lack lineage-specific markers like TTF1. Clinically, unfortunately, they tend to follow a highly aggressive course, and metastases are often present at presentation.
Now, extrarenal malignant rhabdoid tumor, or MRT, we've touched on it as a mimic, but let's focus on it. This is primarily a pediatric aggressor, defined by SWES-NF deficiency, typically involving INI1. What makes this tumor so devastating, and how do we precisely identify it, particularly when facing a pediatric case with rhabdoid morphology?
Extrarenal MRT is indeed a highly aggressive malignant neoplasm that predominantly affects infants and young children, usually under 10 years of age. There's no strong gender predilection. It's rare in soft tissue overall, less than 1% of sarcomas, but when it occurs there, it's most frequent in deep soft tissues of the proximal extremities or limb girdles, pelvis, perineum, abdomen, retroperitoneum, or the neck, often along the vertebral axis.
And the cells. What defines rhabdoid?
It's characterized by these epithelioid cells that have large, eccentrically located nuclei, vesicular chromatin, and very prominent nucleoli. The cytoplasm is abundant and contains those characteristic eosinophilic hyaline inclusion-like structures. These are actually aggregates of intermediate filaments, mostly vimentin and keratin. That's the classic rhabdoid look, and it's a key diagnostic nugget.
Okay.
These cells are usually arranged in solid sheets or sometimes trabeculae separated by fibrous septa, or occasionally even an alveolar pattern. You see numerous mitoses, and necrosis is common. It's important to note that some cases might be dominated by more primitive, undifferentiated round cells with only scattered classic rhabdoid cells. And remember, as we discussed, in adults, just seeing a rhabdoid phenotype is often nonspecific and can occur in various carcinomas, melanoma, or other sarcomas. It doesn't automatically mean it's a primary MRT.
Right. So what's the specific IHC and molecular profile that nails the diagnosis for MRT, especially differentiating it from other tumors that might just look rhabdoid?
Classically, MRTs express vimentin, keratins, and EMA. About 80% are positive for at least one epithelial marker. Around 2/3 express CD99. That keratin positivity is often confined to those globoid paranuclear inclusions. Neural markers like synaptophysin, CD57, and NSE are surprisingly common, seen in over half of cases. SMA and S100 might be positive in a small subset, but usually just focally. They are usually negative for HMA45, melin A, chromogranin, GFAP, CD34, and importantly, desmin.
Okay.
The near-universal diagnostic feature and your golden rule for MRT is the loss of INI1, FERTB1 protein expression by immunohistochemistry. Again, you need to confirm retention and internal controls. A small subset of cases that do retain INI1 expression might instead show serum-A BRG1 mutations and corresponding protein loss.
So INI1 loss is the big one, occasionally serum-ECO4 loss.
Exactly. Molecularly, nearly all MRTs have biallelic inactivation of the SMARCB1 INI1 gene at 22q11.2, which directly correlates with the protein loss. SMARCB1 is a core member of that SWES-NF chromatin remodeling complex. The alterations can be deletions, translocations, monosomy 22, or inactivating mutations. The type of alteration can vary a bit by site mutations, and monosomy 22 are more common in CNS and kidney rhabdoid tumors, while homozygous deletions or translocations might be more frequent in soft tissue MRTs. Germline SMARCB1 mutations can occur, leading to a predisposition syndrome. TP53 mutations are also often found in MRTs.
And the differential, especially in kids.
In kids, the main soft tissue differential is rhabdomyosarcoma, but RMS expresses desmin and myogenin and retains INI1 and is usually epithelial marker negative. Other considerations might include epithelioid angiosarcoma, EAAE, CD31 positive, INI1 retained, PEComas, HMB45 melon, A positive, INI1 retained, myoepithelial tumors, S100G FAPSMA positive, though some malignant ones lose INI1, epithelioid MPNST, S100 strong, but usually in older patients, desmoplastic small round cell tumors, rhabdoid areas possible, but also small cells, collagenostroma retain INI1, EMC retains INI1, KRT negative specific fusions, ASPS retains INI1, TFE3 positive, Proximal type epithelioid sarcoma, while also having INI1 loss, affects older individuals, is less rhabdoid dominant, and has a less rapid course.
And the prognosis is grim, you said.
Highly aggressive, unfortunately, with early death being common. Local recurrence happens in 20–25%, and the metastatic rate is very high, 50–80%. About two-thirds of children diagnosed die within 2 years. The 5-year survival is sadly low, maybe 15–20%. Metastasis typically goes to the lungs, pleura, lymph nodes, liver, and bone. Optimal treatment involves intensive multi-agent neoadjuvant chemotherapy and radiation, followed by complete surgical excision if possible, but responses are often frustratingly short-lived.
Now, let's tackle sclerosing epithelioid fibrosarcoma, or CEPH. This is described as a rare, aggressive variant of fibrosarcoma, a sclerotic mimic of carcinoma. For an inattending, this sounds like one that could look deceptively bland because of the sclerosis and maybe the bland nuclei, making it a major diagnostic trap. How do we differentiate it from other highly sclerotic or epithelial-looking tumors?
Yes, CEPH is definitely a tricky one. It's a rare, aggressive variant of fibrosarcoma, and it's notorious for being confused with metastatic carcinoma, particularly sclerosing types or signet ring cell types. It affects adults, median age around 45, equal gender distribution, and often presents as a painful, deep, soft tissue mass, commonly in the limbs or limb girdles. Rarely it can arise primarily in bone. Radiologically, it often looks deceptively well circumscribed.
Okay, and pathologically, what's the sclerosing epithelioid look?
Pathologically, CEPH typically measures maybe 5–10 centimeters. Grossly, it's often well circumscribed, maybe lobulated. You might see calcifications, cystic areas, or myxoid change. Necrosis is uncommon. Histologically, it's characterized by epithelioid or sometimes clear tumor cells. They are often arranged in thin strands or cords, which can mimic signet ring cell carcinoma, or sometimes in nests or even a sheeny, which might bring paraganglioma to mind.
Wow, lots of mimics just based on pattern.
Exactly, and these cells are embedded in a very distinctive, densely hyalinized, almost glassy collagenous matrix. That dense sclerosis is a key morphologic nugget. The nuclei themselves are often round and relatively bland-looking, and mitosis can be minimal, which adds to the deceptive appearance. It's common to see these sclerotic, hypocellular areas coexisting with more cellular spindle cell zones that look more like conventional fibrosarcoma. You might also see focal myxoid change, metaplastic cartilage or bone, slit-like pseudovascular spaces, or calcified foci. And importantly, infiltrative margins are common microscopically, despite the often well-circumscribed gross appearance. There are also rare hybrid tumors where CEPH coexists with low-grade fibromyxoid sarcoma, LGFMS.
What's the immunohistochemical and molecular landscape for CEPH, and how do we use that to navigate its wide and challenging differential, especially against carcinoma?
Immunochemically, CEPH shows variable EMA staining in about half of cases. S100 and keratins are typically uncommon or negative. CD34, Desmin, SMA, HMB45 are consistently negative. A key diagnostic marker and a real golden nugget for CEPH is MUC4. MUC4 is a highly sensitive marker and is positive in the majority of CEPH cases, including those hybrid forms with LGFMS.
MUC4 is the key stain here.
It's extremely helpful, yes. Molecularly, most pure CEPHs have specific UWSR1 CREB3L1 or UWSR1 CREB3L2 fusion genes. Interestingly, those hybrid tumors, CEPH plus LGFMS, usually have the FUS CREB3L2 fusion, which is the characteristic fusion of LGFMS. A small subset of pure CEPHs can also have FUS rearrangements instead of UWSR1.
Okay, so the differential is wide. Carcinoma, lymphoma, osteosarcoma. How do we sort it out?
Right, the differential is broad, primarily metastatic carcinoma like signet ring cell gastric or lobular breast, sclerosing lymphoma, and extraskeletal osteosarcoma. CEPH is often EMA positive, which can confuse it with carcinoma, but most CEPHs are keratin negative, which helps distinguish it from most metastatic carcinomas. You'd use CK20 CDX2 for gastric, Gata3 or PRE for lobular breast, etc.
Okay.
Epithelioid synovial sarcoma can have trabecular growth and sclerotic stroma, but it's EATR-TTLE1 positive and has the specific TX18 translocation. Myoepithelial carcinomas are typically more cellular, have more myxoid stroma, more heterogeneity, and show KRT-100 co-expression. MUC4 can be a potential pitfall here, as some myoepithelial carcinomas can be focally positive, but it's usually diffuse and strong in CEPH. Both CEPH and myoepithelioma can have EWSR1 rearrangements, so FISH for UWSR1 isn't necessarily distinguishing between them. Sclerosing rhabdomyosarcoma is Desmin myogenin positive and EMA negative. Extraskeletal osteosarcoma can be a very difficult distinction, as both can have prominent hyalinized or osteoid-like matrix and epithelioid cells.
Mhm.
Osteosarcomas usually show more nuclear atypia and definite lacy osteoid production, and MEC4 is typically negative in osteosarcomas.
And the prognosis for Ceph? Sounds aggressive.
It is aggressive. Local recurrences are frequent, happening in 30–50% of cases, and metastases occur in over half of patients, primarily to the lungs, bone, pleura, and other soft tissues. About 15% of patients actually have distant metastases at the time of presentation. About a third of patients die of the disease, often within a few years. Proximal location, large size, and male sex are considered adverse factors, with spine or head and neck locations having the worst prognosis. Treatment involves wide surgical resection, often combined with pre- or post-operative radiation. Unfortunately, the response to conventional chemotherapy is generally poor.
Next up, epithelioid angiosarcoma. This sounds like truly a vascular wolf in epithelial clothing, often presenting in deep soft tissue and capable of extensive mimicry, including expressing epithelial markers. What are the key features to ensure we don't miss this aggressive vascular malignancy?
Epithelioid angiosarcoma is indeed a malignant neoplasm with endothelial differentiation, and the epithelioid variant can be particularly challenging. It's rare overall, less than 1% of soft tissue sarcomas. The deep soft tissue variant typically arises in the lower extremities, especially the thigh, retroperitoneum, or abdominal cavity. It tends to affect middle-aged to elderly adults with a predominance in men.
Okay. And pathologically, how does it look?
Pathologically, it often presents as a large hemorrhagic and necrotic mass, maybe median size 5 centimeters. Histologically, you typically see solid sheets of large epithelioid cells set in a variably collagenous stroma. It often has a multinodular growth pattern and infiltrative margins. The cells themselves have abundant eosinophilic or amphiphilic cytoplasm, usually well-defined borders. Nuclei are large and vesicular, with prominent central nucleoli often quite atypical. You might see vacuolated cells. Sometimes you can find hints of its vascular nature, like slit-like spaces, rudimentary vessel formation, or even papillary or pseudoglandular structures, but often it's just solid sheets. Necrosis and hemorrhage are very common and can sometimes obscure the tumor cells. Mitosis are usually numerous. You can also see a prominent inflammatory infiltrate, lymphocytes, plasma cells, neutrophils, eosinophil cells, which sometimes leads to misdiagnosis as just inflammation or infection initially.
With so many mimics and that potential for keratin positivity, how do IHC and other features definitively confirm its vascular nature and differentiate it from other epithelioid malignancies that might express similar markers?
Right, the IHC is critical. Epithelioid angiosarcoma consistently expresses endothelial markers. CD31 and ERG are generally the most sensitive and specific. FLI1 is also usually positive. While CD34 can be positive, it can also be entirely negative in some cases, especially in poorly differentiated ones, so you can't rely solely on CD34 to rule it out. D240 can also be positive.
Okay, CD31 and ERG are the mainstays.
Yes. Now, the tricky part. Keratins are positive in 30–50% of cases, sometimes even diffusely, which is a major pitfall. However, EMA is almost always negative. Focal SMA positivity is possible. Importantly, INI1 expression is retained.
INI1 retain. That's helpful. So the differential: carcinoma, melanoma, sarcomas.
It's broad and challenging. You absolutely must exclude non-mesenchymal mimics like metastatic carcinoma, especially given the keratin positivity, melanoma, malignant mesothelioma, and even large-cell non-Hodgkin lymphomas. Mesenchymal mimics include cellular or solid variants of epithelioid hemangioma or epithelioid angiomas nodule. These are smaller, usually cutaneous subcutaneous, have less atypia, small and nuclear nucleoli, no necrosis, scarce mitosis. FOSB positivity can help distinguish hemangioma.
And EA.
Epithelioid hemangioendothelioma, EHE, is a key differential. Conventional EHE has less atypia and grows in cords within that characteristic myxohyaline stroma versus the solid sheets of angiosarcoma. The malignant EH variant is intermediate and tougher. Uniform solid growth strongly favors angiosarcoma, while glassy cytoplasm and definite myxohyaline stroma favor EE. The most helpful distinction comes from CAMT1 IHC. EE is typically CAMT1 positive, while epithelioid angiosarcoma is CAMT1 negative. That's a key distinction.
CAMT1 again, crucial. What about epithelioid sarcoma?
Epithelioid sarcoma, especially the angiomatoid variant or the proximal type, can be a mimic. Both can be nodular, have epithelioid cells, and both can be KRT and CD34 positive. However, epithelioid sarcoma is typically EMA positive, angiosarcoma is negative, and CD31 negative, angiosarcoma is positive. And the absolute key differentiator, ENI1 is lost in epithelioid sarcoma but retained in angiosarcoma.
ANI1 status is critical there.
Absolutely. Other mimics. Epithelioid MPNST is superficial, strongly S100 positive, CD31 negative, and often shows INI1 loss. Extrarenal malignant rhabdoid tumor is KRTMA positive, CD31, CD34 negative, and shows characteristic INI1 loss.
And the prognosis for epithelioid angiosarcoma?
It's aggressive. Local recurrence happens in about 20%, and distant metastases occur in about half of patients, commonly going to the lung, lymph nodes, bone, and soft tissue. Sadly, about 50% of patients die within 1 year of diagnosis. Poor prognostic factors include older age, retroperitoneal location, and large tumor size. Treatment involves wide surgical excision if possible, often combined with radiation. For unresectable or metastatic disease, chemotherapy, typically anthracycline or taxane-based regimens, is used.
Lastly, in this section, epithelioid malignant peripheral nerve sheath tumor, or MPNST. This is a rare variant, but its S100 positivity makes it a powerhouse that still requires careful distinction, especially from melanoma. What are the defining characteristics of this rare entity, especially the sign-out bench?
Epithelioid MPNST is indeed rare, making up only about 5% of all MPNSTs. It typically arises in the subcutaneous tissue, less frequently deep. It tends to affect young to middle-aged adults, maybe mean age 35-45. Extremities are the most common location. Unlike conventional MPNST, it's generally not associated with neurofibromatosis type 1, NF1.
No NF1 association, interesting.
Yeah. However, about 30-50% of cases are associated with a large nerve or arise from a pre-existing benign nerve sheath tumor, like a schwannoma. That's a helpful clinical clue if you can get it. Median size is moderate, maybe 3.55 centimeters.
And pathologically, what's the look?
Pathologically, they are usually well circumscribed, especially when superficial and often multinodular. There can be a variable admixture of epithelioid and spindle cells, but the epithelioid component usually predominates. They grow in sheets, nests, cords, or strands, often separated by hyalinized collagen or sometimes myxoid stroma. The cells themselves are relatively uniform, with abundant eosinophilic cytoplasm, rounded nuclei, vesicular chromatin, and usually a single prominent central nucleolus. They can really look quite a bit like melanoma cells.
Ah, the melanoma mimic again.
Exactly. But crucially, no actual melanogenesis, melanin pigment, is present. Mitosis are readily found, and occasional necrosis can be seen.
So given that melanoma-like morphology and the expected S100 positivity, how do we definitively distinguish epithelioid MPNST from melanoma and the host of other epithelioid neoplasms that can look similar? What's the key?
The IHC is critical here. Epithelioid MPNSTs are characterized by strong and diffuse S100 protein and SOX10 positivity. That's a hallmark.
Strong S100 and SOX10.
Yes. They are consistently negative for specific melanocytic markers like HMB45 and melon A, as well as vascular and myogenic markers. Occasional focal keratin or EMA positivity can occur, which is a known potential pitfall. Now, a very important diagnostic nugget. About 2/3 of epithelioid MPNST cases show loss of INI1 SMARCB1 expression. This can be extremely valuable for diagnosis, especially when differentiating from melanoma, which retains INI1.
INI1 loss in 2/3, okay. That's
Whoa.
useful.
Very useful. The differential diagnosis is wide and definitely overlaps with epithelioid angiosarcoma and others we've discussed. You're primarily considering metastatic melanoma, carcinoma, large cell lymphoma, myoepithelial carcinoma, epithelial schwannoma, and other epithelioid sarcomas, like angiosarcoma, epithelioid sarcoma, clear cell sarcoma, PEComa, rhabdomyosarcoma, extrarenal MRT.
So how do you sort them out?
The golden rule to distinguish it from metastatic melanomas. While both are S100 SOX10 positive, melanoma typically shows more nuclear ATP pleomorphism, higher mitosis, is positive for HMB45 melon A, and retains INI1. Epithelioid MPNST lacks HMB45 melon A and often loses INI1. Clear cell sarcoma is also melanocytic positive but retains INI1 and has specific EWSR1 fusions. Carcinomas and lymphomas are excluded by their specific lineage markers. Other epithelioid sarcomas like angiosarcoma, epithelioid sarcoma, rhabdomyosarcoma, or extrarenal MRT never show that strong and diffuse S100 positivity. Myoepithelial carcinoma shows intratumoral heterogeneity is KRTMS 100 positive, and while it can have INI1 loss, the presence of an EWSR1 rearrangement would strongly support a myoepithelial diagnosis over MPNST. Epithelioid schwannoma, which is benign and usually superficial, is also S100 SOX10 strong diffuse, but typically has smaller cells with indistinct nucleoli, grows in nestrobeculae in a myxoid matrix, has rare mitosis, and no necrosis.
And the prognosis for epithelioid MPNST.
Prognosis seems to depend significantly on size and depth. Superficial and small lesions, say under 5 centimeters, generally have the best outcome. While some early studies reported higher metastatic rates, more recent data suggests a lower metastatic rate overall, maybe around 15%, with about 30% local recurrence, somewhat independent of depth. When they do metastasize, the most common sites are the lungs and pleura, less commonly the liver or lymph nodes.
Okay, now for the final section, the shapeshifters. These are other sarcoma types that don't always look epithelioid, but can unexpectedly present with prominent epithelioid features. This is where a really broad knowledge base becomes absolutely crucial for you as an attending pathologist. These are the cases that can really surprise you, right?
Yeah.
Where your meticulous H&E skills combined with ancillary studies become paramount.
These are indeed the ones that demand meticulous attention and a broad differential. Let's briefly cover a few more important entities where epithelioid features are less common but highly significant when they occur, often because they obscure the tumor's true identity. First, epithelioid myxofibrosarcoma. This accounts for less than 5% of all myxofibrosarcomas. When you see it, it's usually a high-grade tumor that can look very carcinoma-like. It's often multinodular, and you typically find these epithelioid areas admixed with more conventional-looking myxofibrosarcoma areas, spindled cells, myxoid stroma, curvilinear vessels. The epithelioid tumor cells have round nuclei, vesicular chromatin, prominent nucleoli, and abundant eosinophilic cytoplasm. Mitoses are numerous, and necrosis may be present. IHC is generally negative for epithelial markers Desmin and S100. The critical diagnostic clue, your golden nugget here, is the identification of these conventional myxofibrosarcoma areas adjacent to the epithelioid regions. This epithelioid variant tends to be more aggressive than even conventional high-grade myxofibrosarcoma, with a metastatic rate over 50%.
So finding those conventional areas is key for myxofibrosarcoma. What about liposarcoma?
Right, pleomorphic liposarcoma, PLPS, epithelioid variant. This also represents less than 5% of all liposarcomas. These occur in the deep, soft tissues, often lower extremities like the thigh, typically in elderly patients. A significant subset, maybe 15–30%, can have prominent epithelioid features, making them striking mimics of carcinoma or melanoma. These epithelioid cells can even show focal keratin or EMA positivity in a minority of cases, adding to the confusion. The critical diagnostic feature and your primary goal when considering PLPS is the unequivocal identification of lipoblasts within the tumor, those multivacuolated cells with scalloped nuclei. This is a high-grade sarcoma with high rates of recurrence, 35–50%, and metastasis, around 50%. And the presence of epithelioid morphology in PLPS seems associated with particularly aggressive behavior.
Lipoblasts are the key for PLPS. What about synovial sarcoma? Doesn't that sometimes have glands?
Exactly. Synovial sarcoma, epithelial glandular variant. This accounts for maybe 5–10% of adult soft tissue sarcomas, found in deep soft tissues of limbs or limb girdles, often near large joints. In the predominantly epithelial variant, the spindle cell component, which is usually present in synovial sarcoma, can be scant and very easily overlooked. That's the challenge here. The epithelial component forms solid nests or distinct tubular or glandular structures, sometimes even pseudopapillary patterns. The epithelial cells are typically large, cuboidal to columnar, with round vesicular nuclei, pale cytoplasm, and distinct borders. The glandular lumina often contain eosinophilic mucin. Squamous differentiation is rare. Crucially, there is always some spindle cell component present, however subtle it might be. Finding it is a key diagnostic nugget. You also often see thick collagen bundles and calcifications.
Okay, always some spindle cells. And the IHC molecular.
IHC shows consistent keratin and EMA positivity in the epithelial component. CEA can be focally positive. CD99 and sometimes S100 can be positive in the minor spindle cell component. TLE1 is a sensitive nuclear marker that's positive in most synovial sarcomas. CD34 is negative. Molecularly, it consistently bears that highly specific TX18 translocation, leading to the SS18, SSX1, or SSX2 fusion. This is specific to synovial sarcoma and can be detected by FIH or RT-PCR, providing definitive diagnostic certainty.
And the differential for glandular synovial sarcoma.
The differential includes metastatic adenocarcinoma, especially if the spindle component is missed. Carcinosarcoma, the rare glandular MPNST, often has goblet cells, neuroendocrine markers associated with NF1, endometriosis, if near pelvis, and mixed tumor myoepithelioma. Purely glandular patterns can absolutely be confused with adenocarcinoma. The keys are identifying that subtle spindle cell component, considering the typical clinical presentation, young adult extremity, and confirming the pathognomonic TX18 translocation.
So the key message, particularly for these shapeshifters, seems to be hypervigilant and actively look for those more conventional areas, even if they're subtle. They're like hidden clues.
Precisely. And that's the practical tip that really underpins this entire discussion of variants. For all these epithelioid variants, whether it's dedifferentiated liposarcoma showing epithelioid change, or clear cell sarcoma, especially in metastases, myxoinflammatory fibroblastic sarcomas, epithelioid EMC, epithelioid leiomyosarcomas, desmoplastic small round cell tumors, or the epithelioid variant of inflammatory myofibroblastic tumor adjacent to the overtly epithelioid areas. Most of these tumors will retain some more conventional histologic features. It's your job as the pathologist to meticulously search for these less epithelioid areas, hunt for lipoblasts in suspected PLPS, look for the spindle cells in synovial sarcoma, find the myxoid areas and curvilinear vessels in myxofibrosarcoma. These areas often provide the critical clues for proper recognition and diagnosis. Don't let the dominant epithelioid change completely obscure the tumor's underlying identity. A broad differential, careful H&E examination, and a smart, targeted IHC and potentially molecular strategy are your best friends in tackling these shapeshifters. #tag outro.
Okay, let's unpack this. What a journey through the really complex and often perplexing world of epithelioid soft tissue tumors. We've seen their incredible morphologic variability, their challenging mimicry, but we've also armed ourselves with some powerful diagnostic tools. From using critical clinical context and meticulous H&E examination to the indispensable power of immunohistochemistry and the increasing precision of molecular studies. That systematic approach we walk through really does feel like your compass for independent sign-out, doesn't it?
It really does. And that compass, this deep dive, hopefully should equip you, our new attending listener, with increased confidence for that independent sign out. It's not just about memorizing lists of tumors or stains, it's about fostering a critical layered diagnostic mindset. Remember the importance of recognizing the mimics, those entities that look like epithelioid sarcomas but aren't, and leveraging the specific immunoprofiles and molecular signatures that truly differentiate these entities. That's where you'll make the biggest impact for your patients, ensuring those accurate diagnoses that drive appropriate therapy.
What's fascinating here is just the continuous evolution of our understanding of these tumors, isn't it? Especially with new molecular insights that seem to be constantly reshaping how we diagnose and even treat them.
Absolutely. It's a dynamic field.
It really is. And this raises an important question for you, the listener, as you embark on your independent sign-out journey. How will you personally integrate this multi-layered approach, weaving together the patient's story, your careful look at the H&E, the IHC panel, and maybe even the most cutting-edge molecular tests? How will you bring all that together to ensure the most accurate and impactful diagnoses for your patients, particularly in those truly ambiguous cases that challenge even the most experienced among us?
That's the ultimate challenge, isn't it? And really the ultimate reward of being an independent pathologist. It's about more than just getting the right label. It's about guiding patient care effectively.
Exactly. So what does this all mean for your practice? Keep exploring, keep questioning those challenging cases, and keep making those confident diagnoses. We'll catch you on the next deep dive.